Hello and welcome to Inside Ophthalmology. I am Dr. Amrit and today we are going to discuss the management of age-related macular degeneration or AMD. I am not going to go into the pathophysiology in detail since we have already covered that. Instead, we'll focus on what really matters, clinically when to treat the patients and what exactly to do in dry and wet AMD. Before we jump into treatment, let's just quickly revise how we classify AMD because this actually guides the management. This classification is based on what you see within 2 disc diameters of the fovea. So starting from the beginning, you can have no apparent aging changes. That means here there will be no drusen or no pigmentary abnormalities. Then you can have what we call normal aging changes. Here we see small drusen or drupelets less than 63 microns and still no pigmentary changes. Now once the drusen becomes a little larger, we will enter the disease. This is early AMD. Now drusen size is between 63 and 125 microns but still no pigmentary abnormalities. So remember, in early AMD you have intermediate size drusens but no pigmentary abnormalities. And as things progress further, we reach intermediate AMD. In intermediate AMD, we have large drusens more than 125 microns or any definitive pigmentary changes. These pigmentary changes basically mean hyper or hypopigmentation associated with drusen and not due to something else. And finally, we have the late AMD, which includes macular neovascularization and geographic atrophy. One practical point over here, if you are trying to estimate drusen size clinically, just compare it to a retinal vein at the disc margin. That's roughly 125 microns. And one very important clinical takeaway over here would be that if a patient already has advanced AMD in one eye, the risk of developing advanced disease in the fellow eye is pretty high, around 50% over time. So these are the patients where we really need to be proactive. So now based on this, let's focus on dry AMD management. And remember, here the main goal is not to improve vision, but to reduce the risk of progression to advanced disease. Now the first practical question is, who should we actually treat? Because not every patient with drusen needs supplement. So what did the AREDS study tell us? AREDS stands for Age-Related Eye Disease Study. And it says that if you have a patient above 55, you examine them and look for certain high-risk features. And what are these high-risk features? These include intermediate drusen, especially if they are extensive, any large drusen, geographic atrophy in one or both eyes, and very importantly, advanced AMD in one eye. Now that last group is very important because here you're not just managing the affected eye, you're also trying to protect the fellow eye, and this is where the maximum benefit was seen in AREDS study as well. So naturally, the next question is, does it actually work? Yes, but only in the right patients. In these high-risk groups that we discuss, AREDS showed about 25 to 30% reduction in progression to advanced AMD over about 10 years. That's quite meaningful clinically. But at the same time, if the patient has only early AMD or no AMD, these supplements don't really help. So this is not something you prescribe to everyone. Remember that. Now coming to what exactly we prescribe. We follow the AREDS2 formulation. You don't need to overcomplicate it, just remember the key components: vitamin C, vitamin E, lutein, zeaxanthin, zinc and copper. So that's your standard combination. Now the AREDS2 tried to improve the original AREDS1 formulation. So what actually changed? The biggest issue was with beta carotene. It was the part of original formulation, but it was found to increase the risk of lung cancer, not just in smokers, but even in former smokers. So what happened? It was removed and it was replaced by lutein and zeaxanthin. They are safer and probably more relevant for macular protection as well. Then comes the zinc. The AREDS1 formulation had high doses of zinc and that was causing side effects like gastrointestinal and genitourinary toxicity. So people started using lower doses around 25 milligrams, and the good thing is they seem to work just as well and are also better tolerated. And finally, omega-3 fatty acids. There was a lot of expectations with omega-3 fatty acid, but studies showed that there was no additional benefit. Nevertheless, they are a part of the AREDS2 formulation. Now, many examiners like to ask you about the doses of the AREDS2 formulation, and they are appearing on your screen right now. You can remember that for your examinations. Now, coming to something newer, and these are the complement inhibitors. This is mainly for patients with geographic atrophy. So what are we trying to achieve here? Not just visual improvement, we are trying to slow down the progression of atrophy. That's it. So 2 drugs you should know. Number 1 is pegcetacoplan, which is a C3 inhibitor, and avastin captad-pegol, which is a C5 inhibitor. And both of them act on the complement pathway. So when you counsel the patients, be very clear. You can say that with these drugs, we may slow the progression of the disease, but this will not improve your vision and this will not cure the disease. Apart from that, lifestyle advice is still important, especially in early disease. Here, most important is smoking cessation. So ask your patient to stop smoking. Then, diet also plays an important role. A diet rich in green leafy vegetables, omega-3 fatty acids, and antioxidants is mandatory. And some protection from excessive sunlight also helps. And then there is this oily fish, and there is some supportive evidence regarding the benefits of that as well. So overall, dry AMD management is quite straightforward. You identify the high-risk patients. You give those high-risk patients AREDS2 supplementation where indicated. You consider complement inhibitors in geographic atrophy, and you advise lifestyle modification. At this point, I would like to ask you one question. Why do you think copper was added into the AREDS2 formulation?